A 37-year-old male reports lower back pain that has persisted for 1 month. He experiences stiffness in the morning and notes that the pain often follows vigorous exercise. Physical examination shows limited range of motion during forward bending and tenderness upon palpation, but no neurologic deficits are found. This presentation is common. Low back pain is the leading condition globally that stands to benefit from rehabilitation. It has a point prevalence of 12% in the general adult population and a lifetime prevalence of 40%, making it a primary cause of disability. Despite these high rates of occurrence, clinicians find that 80 to 90% of these cases lack a clear nociceptive cause. These are classified as nonspecific. A nonspecific classification defines pain that occurs without an identifiable anatomical lesion. In these cases, there is no herniated disc, spinal stenosis, or fracture to account for the patient's symptoms. Defining low back pain as a symptom identifies it as a clinical problem that exists independently of structural damage. When clinicians use a traditional medical model to hunt for anatomical defects in these patients, they often miss the actual mechanisms driving the pain. When back pain persists, the standard clinical reflex is to order structural imaging to find a physical abnormality that explains the discomfort. Data shows that findings on these scans, such as disc degeneration or modic changes, frequently fail to correlate with the intensity of the patient's pain. Biological, psychological, and social factors interact to produce this pain experience. This complexity moves the clinical problem beyond the scope of a simple mechanical failure of the spinal column. Managing these cases effectively requires clinicians to move beyond structural defect hunting. The objective is to stratify patients based on their biopsychosocial phenotypes. Relying solely on spinal anatomy can lead to treatment plans that overlook the behavioral factors often responsible for chronic disability. To understand how this phenotyping works, we can follow a standard diagnostic workflow. This funnel represents 100% of acute low back pain cases entering primary care. The first step is to rule out dangerous causes. Only about 5 to 10% of cases involve red flags like cancer, infection, or trauma. This leaves approximately 90% of patients in the non-specific category. For this 90%, the clinician must decide whether to perform a scan. Practice guidelines from 8 international bodies, including those in the US, UK, France, Germany, and Canada, unanimously agree that routine imaging for this group is not recommended. This consensus exists because routine imaging for non-specific pain does not improve patient outcomes. Instead, it frequently leads to unnecessary invasive procedures. There is also a psychological risk. When a patient sees images of normal, age-related spinal degeneration, they may develop fear avoidance behaviors that increase the risk of long-term disability. Imaging is only justified when a clinician is actively planning an invasive procedure, or if new red flags emerge during the course of care. Because diagnostic imaging for the 90% majority is often unhelpful or even harmful, clinicians must rely on a different set of diagnostic tools to triage their patients. Low back pain is a long-lasting condition with a variable course over time. It is rarely a series of isolated, unrelated episodes. Research has identified 3 primary pain trajectories over a 12-month period: rapid or gradual recovery, ongoing or fluctuating pain, and persistent severe pain. Approximately 70% of acute cases follow the recovery trajectory, with pain levels abating significantly within the first few weeks. The clinical priority is identifying the remaining 30%. These patients are at risk of moving into ongoing or persistent pain trajectories. Since structural scans cannot predict these curves, clinicians use a flag system to phenotype the patient's biopsychosocial risk. Yellow flags are psychological factors. These include distress, negative illness perceptions, depression, and high levels of anxiety. Blue flags represent occupational factors, such as a patient's beliefs about their ability to work while in pain. Black flags describe the systemic context, including financial problems or disability compensation claims. Clinicians use validated screening tools, such as the Start Back tool or the Orebro questionnaire, to detect these flags during the initial encounter. These tools are effective because they accurately predict long-term disability and work absenteeism, which are the primary drivers of the chronic low back pain burden. Once a patient's chronicity risk is phenotyped, treatment follows a universally agreed-upon hierarchy. Systematic reviews of international guidelines show a high level of consensus on the baseline for conservative care. Across multiple countries, first-line treatments are strictly non-pharmacological. The guidelines reach a consensus on physical activity. Supervised exercise, aerobic programs, and a rapid return to daily function are the standard of care. While bed rest was once a common prescription, modern guidelines now explicitly advise against it. For psychotherapy, cognitive behavioral therapy is recommended to address the identified yellow flags. The goal of CBT in this context is to dismantle fear avoidance behaviors that trap patients in a cycle of physical deconditioning. For high-risk patients, the consensus favors multidisciplinary rehabilitation. These programs combine physical components with psychological and social support. Medications appear in the pharmacological column as second-line options or for managing acute flare-ups. Oral NSAIDs are the preferred choice when medication is required. The efficacy of acetaminophen is highly debated, and opioids are heavily restricted due to the lack of evidence for long-term benefit. Global medical consensus places the focus on patient empowerment and movement, moving away from a reliance on the prescription pad and the MRI machine. We can now apply this evidence-based framework to the 37-year-old male from our opening case. Step 1. A physical exam rules out red flags. With no neurologic deficits, the screen is negative and no imaging is ordered. Step 2. A biopsychosocial screen reveals low risk for chronicity. The final step, prescribing reassurance, education, and continued physical activity. A non-specific classification signals that critical clinical data is biopsychosocial, shifting the focus away from biomechanics. Aggressive phenotyping of psychosocial risk allows clinicians to accurately triage patients into their likely recovery trajectories. Effectively addressing this worldwide cause of disability requires a true clinical commitment to the patient's context and behavior.